Enamel is the hardest tissue in the human body, but once bacterial acids breach it, a carious lesion accelerates. It spreads through the softer underlying dentin, directly threatening the tooth's structural integrity. A dental restoration is a precise biomechanical intervention. It replaces lost tissue with a material designed to survive the extreme physical environment of the human mouth. Success depends on balancing the triad of oral health. The clinician must restore biological pulpal protection, ensure mechanical load distribution across the tooth, and recreate the aesthetic form. Every preparation requires negotiating a compromise between the biological limits of the living tooth and the physical properties of the chosen restorative material. This negotiation dictates the physical shape of the cavity. A preparation may require a deep geometric box with sharp internal walls or a conservative sweeping cut that barely touches the enamel. The clinical protocol, the moisture control parameters, and the macroscopic shape of the preparation are dictated by one factor: whether the material stays inside the tooth via macromechanical interlock or micromechanical chemical adhesion. Long-term preservation of the natural tooth depends on navigating the precise mechanical and chemical requirements of these materials. The foundational principles of modern operative dentistry were codified in the late 19th century by G.V. Black, who standardized the use of dental amalgam. On a dental X-ray, the bright white areas indicate amalgam restorations. This opacity confirms a high metallic density. Amalgam possesses excellent compressive strength, but because it does not bond, it sits inside the tooth as a completely distinct, separate physical block. Without chemical adhesion, the clinician must physically engineer the retention. The tooth must be carved into a specific macroscopic shape to trap the metal inside. Retention form angles internal dentin walls inward, locking the hardened amalgam against upward dislodging forces. Simultaneously, resistance form uses a flat pulpal floor and rounded internal line angles to distribute heavy downward forces evenly, preventing the remaining tooth from fracturing. G.V. Black's mechanical system relied on the doctrine of extension for prevention. To create physical geometric locks, the clinician must drill past diseased tissue, sacrificing healthy enamel and dentin to achieve the necessary depth and angles. Despite tissue removal, amalgam remains viable in high moisture areas. Over time, the metal corrodes, producing byproducts that physically pack into margins, sealing the interface. Mechanical retention provides exceptional durability, but it prioritizes the geometric needs of a metal alloy over biological tooth structure. Modern operative dentistry prioritizes minimally invasive dentistry. High-spade rotary instruments selectively carve away only diseased tissue, leaving the healthy surrounding enamel intact. This conservative approach relies on composite resin. This material is composed of an organic bis-GMA resin matrix embedded with rigid inorganic silica fillers. Because composite chemically bonds directly to the tooth, the extensive enamel removal and deep geometric boxes required for amalgam are unnecessary. The adhesive protocol begins by applying a 30 to 40% phosphoric acid gel directly to the prepared cavity. Acid dissolves inorganic hydroxyapatite minerals, exposing a microscopic collagen web. Next, liquid adhesive resin flows into these microporosities, permeating the collagen matrix. Upon curing, this forms the hybrid layer, a microscopic interlocking zone bridging polymerized plastic and natural tooth. Achieving this chemical bond requires absolute moisture control, typically through rubber dam isolation. Dentin bonding requires the exposed collagen mesh to remain slightly moist to prevent fiber collapse. However, the site must be entirely isolated from contamination by drops of saliva, traces of blood, or crevicular fluid, destroying the bond. Managing a successful chemical bond requires a clinician to meticulously monitor a delicate biological interface at a microscopic scale. While composite restorations are highly aesthetic and tissue conservative, the application process is technique sensitive. The primary mechanical challenge of composite resin is polymerization shrinkage stress. As the resin polymerizes under an LED curing light, molecular chains pull together, causing physical contraction. In a large single block of composite, this shrinkage stress tears the hybrid layer bond, pulling away from the dentin wall and creating a microscopic gap. To limit this internal stress, clinicians must place and cure the composite in small 2 mm increments. If a gap forms from shrinkage stress or moisture contamination, it results in microleakage. Oral fluids, acids, and bacteria penetrate the unprotected space. This microleakage is the direct cause of postoperative sensitivity. Fluid movement within the microscopic gap irritates the dentinal tubules, triggering pain in the pulp. Left unchecked, microleakage leads to secondary caries. Bacteria fester underneath the permanent restoration, rotting the tooth from the inside. A restoration is only as durable as its marginal seal. If the chemical interface fails, the entire biomechanical structure is compromised. Material selection, amalgam, composite, or glass ionomer, is a structural engineering decision based on clinical variables. Every restorative procedure begins with a decision algorithm based on cavity classification. The clinician identifies if it's a high-stress posterior zone requiring compressive strength or an aesthetic anterior zone. The ultimate limiting factor is achieving absolute moisture control. If isolation is impossible, resin bonding fails. In these cases, traditional amalgam or glass ionomer cements are required. Glass ionomer provides a moisture-tolerant, acid-base chemical bond when resin cannot be used. If absolute isolation is achieved, the clinician proceeds with minimally invasive dentistry, utilizing direct composites or bonded ceramics to restore the tooth. The highest standard of care requires mastering mechanical and chemical systems, utilizing adhesion to preserve biology, and deploying mechanical retention when the environment demands it.